and welcome to this episode 7 of RTMatters, where candid conversations take place about what matters most to respiratory therapists. I'm Patrick Dunn, your host, and I'm delighted to welcome you to our podcast. Now, before we begin this episode, a few housekeeping details to attend to, especially for our first-time listeners. First of all episodes are available through your podcast app of choice. It's open access, no charge, no subscription fee, and no membership required. Second, we really want your feedback. That's right, we want to hear from you, our listeners. We want your thoughts about this or any prior episodes, and also any requests for additional information that might be mentioned during the podcast. Email us directly by hitting the link feedback@rtmatters.com, which is in the description at the beginning of each episode. And RT Matters now is the virtual voice of respiratory therapists everywhere, so feel free to tell your fellow RTs about this important new resource. Now, on to our episode today. This is the question. This was, now that I have my RRT, so what's next? And this is actually a follow-up to an earlier podcast we did with Ed Coombs, episode 2, where we talked about the fact that RT is indeed not a dead-end career. There are many, many options within the profession. Today, we're going to talk to someone who has actually gone beyond the traditional way. Our guest panelist is Kevin McQueen. Kevin is a registered respiratory therapist. He also has successfully sat and passed the adult critical care specialty credential. He also is a certified professional in patient safety, and we'll talk more about that. And he's also a fellow of the AARC. He's currently the system lead director of respiratory care at the University of Colorado Health System. And in that position, he oversees respiratory care services across 14 hospitals located throughout Colorado. In addition to that, his full-time job in Colorado Springs, he has regional responsibilities over pulmonary diagnostics, pulmonary rehab, sleep disorders, hyperbaric oxygenation, wound care, and diabetic education. Kevin, welcome to RT Matters.
Thank you for having me, Patrick.
All right. Well, let's get started. First of all, they say if you want something done, give it to a busy person, and you certainly qualify. But one of the features of RT Matters is we always like our listeners to know how our invited guests learned about respiratory care. And the question is, did you find it or did it find you? And I believe you actually first learned about it when you were on active duty in the U.S. Air Force.
Yes, back in the mid-1980s, I was serving in the Air Force, and I had the pleasure of working in intensive care units and emergency departments. And a lot of my duties were around ventilator management, blood gas analysis. And when I got out of the service in 1989, I had to think, well, what was I going to do with myself? And I looked into whether or not to go into nursing school or respiratory. And it kind of fell in my lap because nursing school at that time had a 2-year waiting list. And when I contacted the RT school, they said, we're going to start in 2 weeks. You can come join us. I always thought I might go back and think about nursing, but I fell in love with respiratory and I've never looked back since I started.
Yeah. Well, you obtained your associate degree in respiratory in 1990 after you were discharged. But you later went back and got your baccalaureate degree in 2012, and you didn't stop there. You also went back and returning up your master's degree in healthcare administration. So looking back, what prompted you to continue your education after you got your entry-level degree?
I've always been a lifelong learner, but I also had the benefit of a lot of the training I learned in the military around leadership helped to get me promoted all the way up to the director level. But sadly, I only have my associate degree, and a change in the C-suite leadership of the hospital, the new leaders came in and let me know that I wasn't able to be in the position I was in without my bachelor's degree.
So this is you were a director in a civilian hospital following your respiratory therapy education. You had your RRT, and you were running a department, and a new administration came in.
They came in and they say they had a totally different philosophy and said you can't be in the job you're in unless you had your bachelor's. So it kind of lit a little fire under me. I went back and I got my bachelor's, and I took off less than a year, and then I went back and got my master's.
And you haven't stopped since. You're still daily education and trying new careers, which we'll talk about in a moment. Now, earlier in your career, you also joined both the AARC and later when you moved to Colorado, the Colorado Society. And as it turns out, you served as president for 2 years from 2020 2022. And now you represent Colorado in the House of Delegates. And you continue to serve on numerous committees. What prompted you to volunteer your time on top of everything else that's going on to serve your professional societies?
It started back in the early 2000s, and I had the opportunity to be a speaker at one of the ARC Congress. And when I went to the Congress, I started meeting people. I started networking with other amazing RTs. And slowly, I just kept getting more and more involved. When I moved to Colorado about 8 years ago, they told me they had a need for someone to help run their southern region and help set up their conferences. I jumped onto that opportunity. Within a year, they asked me to run for president, and I ended up running and getting elected for president. And I had the great pleasure of serving during COVID, which was a lot of challenges, but It was a great time to be an RT and a horrible time to be an RT. So
one of the things that I'd read is that out of the bitter soil of COVID, a flower bloomed, and that was the recognition by most people in the healthcare community of how important respiratory therapists were, especially with the COVID exacerbation of their symptoms and the need for high-tech clinical care in the intensive care unit.
Yeah, I think COVID taught us a lot, and I think RTs really stepped up to the plate and shined all around the world.
Yeah, unfortunately, we lost some of ours that paid the highest price, but it was certainly a real awakening for us and for healthcare in general. Well, now on to the focus of this episode. Now that I have my RRT, so what's next? And the reason for that, we're seeing a lot of online discussion by newer RT grads and some seasoned vets wondering if they made the right choice in pursuing respiratory care. And some people are even saying, well, I'm just going to leave it and go somewhere else. What do you think about that? I mean, you've had so much time and effort already invested. What would you say to these folks who basically just want to throw up their arms and walk away?
I have to say that I've always tried to tell RTs and RT students that the career field is only limited if you let it be limited. It's not a box. You can live well outside that box and still be an RT. I really try to promote it. I met with a bunch of students yesterday at a local college, and I really try to tell them the RT is your stepping stone. From there, you can do so much. And the higher you get with your bachelor's or master's, the more doors that can open.
So there's no question you recommend the associate degree graduates get their bachelor's degree at a minimum. And then if they really want to go in academia or management or other into industry, the master's degree is probably recommended as well.
I 100% support. I believe that our profession has to start stepping up and getting more in line with the other professional physical therapists, even dietitians have a requirement of a bachelor's degree. So I firmly believe that we need to push our all of our RTs to get to the bachelor level and beyond. If they have the desire to keep going, the doors will open more if you continue with the education.
Right. There's no question about it. Several states are talking about upping the requirement to take licensure to the bachelor's degree. And I should point out there's also many online options that exist. So it really is not beyond the realm of possibility, no matter where you live. Now, for those who really like working directly with patients and they want to stay in respiratory care, they just simply want to do patient care. What can they do after they get their RRT credential to kind of make themselves look a little bit better than their colleagues who just basically want to stay as an RRT? Nothing wrong with that. But at the same time, we're trying to give career options.
I think the importance of going on to continue and get other credentials or other certification, it really speaks volumes to our fellow clinicians. When you look at nursing, you look at physicians and stuff, a lot of them have subspecialties. So having specialty credentials like the ACCS, Adult Critical Care Specialist, the NeoPED Specialist, the asthma educator, these help set people apart from a generalist RRT. It tells other clinicians that this individual they're looking at really wants to invest in their specialty. So if they work in a neonatal intensive care unit, getting the NeoPED specialist gives you a nice higher credential that shows people your dedication to that specialized care.
We were talking earlier, you mentioned that you went for the ACCS credential and you challenged your staff to do the same thing. Basically, I think you said I wouldn't ask them to do something I wouldn't do. I think that's a remarkable leadership trait.
When I came here to UC Health in Colorado, I was really trying to bond with my team. So I challenged them. I put in a proposal to get enough money to get a training program for 20 RTs. That was the initial year. And I asked all the supervisors and managers and myself, and then frontline staff to join together and do the ACCS. And it was funny because I had people coming up to me and they said they were nervous to take the test because they didn't want to fail in front of me. And I looked at them and I said, how do you think I feel if I fail as the leader in front of all of you? So it was a great challenge. I enjoyed it. And we now have about 70 of our RTs out of 100 that have specialty credentials.
Well, that says an awful lot for your motivation and for your leadership styles. I should also point out that these specialty credentials are offered through the National Board for Respiratory Care. Now, how about the newest career option is this advanced practice provider? What do you know about the advanced practice respiratory therapist, and what are your thoughts on that?
Patrick, if I was 20, maybe 25 years younger, I would be jumping all over this new field. And we try to tell everybody the APRT is not a higher level of respiratory therapist. It is an advanced practice provider, the same as a physician assistant or nurse practitioner or certified anesthesia assistant. This is a tremendous jump for our profession. It allows us to go from the bedside care provider literally to one of the total care providers, one of the people who direct the care. Right now, as you know, there's only one school in the nation, but it is going to start opening up more and more. So I really look forward to what 5 to 10 years will do to us. If people love respiratory care, and I'm one of them, I love respiratory care. I've always loved making people breathe better. The APRT will allow people to be the leaders in our profession, right alongside pulmonologists and other physicians supporting advanced levels of care.
When I was in the academic world, several of my students went on to become PAs because that was the option. Several actually went on to medical school, but the PAs, they would come back to me and they say, I get flack that I'm kind of bailing on the profession, but yet I'm doing respiratory care in primary care and I'm having a greater impact, and I'm still a respiratory therapist. I think that's the beautiful thing about this whole advanced practice. You're still a therapist. You're just advancing at a higher level, and you're allowing yourself to be more of a disease manager and a more comprehensive provider.
I think with all the chronic lung disease that we currently see and what is expected with the aging population, we can't go wrong. I would love to see a lot of RTs go on to the APRT and stay in this focus area. You can go to become a PA, and that's a great field too. My middle daughter is a PA, but you've already invested so many years to become a respiratory therapist. It's just like a physician that graduates and then goes on to become a pulmonologist. They're specializing in that field. So to me, an APRT is just an extension of our wonderful profession, taking it to the next level.
Right. I'm seeing a lot of the state licensing boards are looking to redo their licensing scope of practice to include APRT. Obviously, there's all kinds of licensing requirements that has to change, but there's more momentum there than ever before. And it was primarily driven, I should point out, by the medical groups that came to us and said, there's a shortage of pulmonologists and critical care physicians. We need you to step up. So it's not something that we're promoting. It's something that we're responding to the request.
Yeah, and I want people that are in this profession to know, if you study what happened with physician assistants, it started with one state and then 2 other states and then 2 more states, and then all of a sudden it spread across the country. APRT will spread the same way. It's going to take a couple of years, but once it gets traction, we're going to see it as a commonplace in healthcare.
Mm-hmm. We're already seeing it in the VA. They hired several graduates from the inaugural class at Ohio State, and Mindy Conklin and her colleagues are just doing wonderful things. Of course, the VA is the largest healthcare system in the United States in terms of employees, so it's a great place to start.
Yes.
Now, look, you mentioned earlier about the certified asthma educator credential, but also with pulmonary rehab, there's an option there that the AARC and the AACVPR, the American Association of Cardiovascular Pulmonary Rehab, they also offer certification programs.
Yeah, I've worked in pulmonary rehab for 8 years in San Diego. And then when I moved here, I'm kind of blessed. I have probably one of the largest cardiac pulmonary rehab departments I've ever seen in the country. They let me know today they had 235 active patients. So that's a large cardiac and pulmonary rehab department.
Dr. Tom Petty is smiling down on you right now. I remember talking to Dr. Tom as his patients called him, and he loved that moniker, by the way, Dr. Tom. He wrote a book in 1988 about pulmonary rehabilitation, and everybody dismissed it as being pie in the sky. These people are not rehabilitatable. You can't improve their quality of life. They won't quit smoking. And today, look at his legacy.
I have to say, in my career, I love critical care. I love the ED. But the most rewarding I ever had was in pulmonary rehab, because you take patients that can barely function, they're withdrawing from life. And with the training and support, both emotionally and physically, they get better and better. And the quality of their life improves tremendously. It's so rewarding to see the change in them. And our staff really promotes this profession. And our entire team have gone and done the ARC's cardiopulmonary rehab program and got their certification. It's truly, and we belong to the AACVPR. So it really is an amazing field. I highly recommend people that want to see a major change and improvement in patient condition.
Especially patients who have been pretty much written off as not salvageable. And I hate to use that word, but that's the mindset. And I must say, when I talk to my colleagues and your colleagues who are in pulmonary rehab, and I just mentioned it, they get so excited because they're doing such a great thing for people who most people just dismissed. And the problem is only 3% of our COPD patients get the referral. I'm sure that's probably higher in Colorado because of the awareness.
It's the awareness and our altitude. We're so high up our elevation that we start seeing patients with symptomatic lung problems probably about 5 to 10 years younger than you would at sea level. So you see a lot of people on oxygen in their 50s here.
Now, one of the questions that comes up online is whether or not respiratory therapists have a role in telehealth and in some cases telepulmonary rehab. What have you seen? I know there's a problem with the emergency authorization that's going to expire soon, and I guess there's a bipartisan effort in Congress to extend permanently the telehealth reimbursement, at least for primary Medicare. Any experience there with the telehealth that you can share with us?
So our cardiac and pulmonary rehab, during COVID, we had so many patients that needed care and couldn't come into the hospital. So we worked with our state public health agency, and we got a grant to supplement our federal abilities. And we opened up telepulmonary rehab and telecardiac rehab, and we have had tremendous outcomes. The improvement has been outstanding. So we're 100% supportive of it. Colorado is very stretched out and has a lot of rural areas. So do many states throughout the country.
Sure. So, especially as you get past the Midwest over to the West Coast. One of the pushbacks that I see in the literature, and it's a soft pushback, is that with telepulmonary pulmonary rehab, you miss that socialization that occurs when the patients are in a position and place where there's person-to-person pulmonary rehab. How have you addressed that? And I could call it a soft pushback because something is better than nothing.
Yeah, and I'd have to say, I agree that the best cardiac and pulmonary rehab is when you have face-to-face with a group, because the group feeds off of each other and gets stronger and stronger. But we've had very good results with our telehealth program, and they work face-to-face on camera while they're exercising with their exercise physiologist and respiratory therapist. But they also, once a week, they have a group session and they do some educational stuff, and the teams reward each other for what they're doing. They help promote each other and push each other. Oh, you went 2 more minutes, so they get excited to help each other. So not as wonderful as face-to-face, but it really still is effective. Sure. It's better because some people can't drive 2 hours, 3 days a week or 2 days a week. This is an effective form.
Yeah, there's no question. And with some of the wearable technology today, we can also add another layer of safety, which was another pushback. Well, how do you know they're capable of carrying on? Well, we can now monitor that with telemetry. So it's really kind of technology being our friend here.
Yes, we have that technology, and we send it to them in the mail, and we monitor them, and we monitor their weight and all their vital signs while they're exercising.
Mm-hmm. Well, that's really good to hear. And I just want our listeners to realize that pulmonary rehab is not going to go away. It's going to get stronger and stronger because the patient population requiring it is going to grow in the next 12 to 15 years significantly. I like to say people in their 60s and 70s are becoming Medicare aged. Unfortunately, they're still doing what they started doing back in the 1960s and 70s, which is have a love affair with cigarettes. So the patient population is there. Now, let's take a look at some of what I call peripheral fields. And you mentioned that respiratory care, in your opinion, and I agree, is kind of a springboard. You know, it's a good place to start your journey in healthcare, and there are many, many, many options. But now I want to go ahead and talk about the fact that they say, well, you know, if you want to do this, the job description requires you to be an RN. If you want to do this, the job description in this hospital requires you to be a medical social worker. You had a nice little anecdote about what happened when you tried to get involved in some of these peripheral risk management organizations.
Yeah, multiple times throughout my career, I've kind of run into a little short wall, and it's a job description that says it requires an RN. And each time I was blessed to have C-suite members that were open-minded when I talked to them and said, my clinical training is very similar to a nurse. I can do this. I can review the charts. I can review the care just like a nurse. And they took the chance with me. I ended up managing the second busiest emergency room in San Diego County with 120 RNs and at that time LPNs. And I ended up being in risk management, a patient safety officer, and many other areas well beyond. And all I did is got them to think and give us a try.
Mm-hmm. And that's what
RTs can do it.
That's right. Absolutely. Well, one of the areas that you were involved with early on was quality performance improvement. And they had the Certified Professional in Healthcare Quality Credential. Tell us a little about what that job responsibility is all about.
So when you work in quality, and I've had a couple of my staff recently move over into the quality department, and I had to tell them that these were people that really like working with data and doing spreadsheets and information. I said, well, you're going to go from helping one patient at the bedside at a time. You are now going to help save hundreds of lives. You're going to help improve large groups of people by doing data analytics with quality teams and helping to drive improvement. So people that really like numbers and like graphs and like digging in to figure out what the root causes of poor care or less effective care. Mm-hmm. This is an area they can extend their abilities tremendously. And it's a very lucrative field. So going outside of just respiratory and expanding can be a very good career move.
But also with your respiratory therapy discipline behind you, which has your ability to be functional in that capacity. And I should point out, this is offered by the National Association for Healthcare Quality, and it's also highly endorsed by the Joint Commission, this quality improvement. And I remember back in the 1980s when I was a home care surveyor for Joint Commission, that whole concept of performance improvement, quality assurance was just coming into vogue. And now it's an absolute linchpin for any high-level analytics for any health system. All right, now let's talk about your love, one of your loves, all of your loves, which this one is really good because when I first got to know you was patient safety. And now there's a Certified Professional in Patient Safety, CPPS. You have that credential. Tell us a little bit about how you got your interest in patient safety.
So I was working in San Diego, and I had a chief nurse and a consultant come up to me and ask if I ever thought about being risk management. And I said, well, only time I've ever seen a risk manager is it's usually a nurse or it's an attorney. Immediately said, Kevin, you can do this. So I was offered the opportunity to go get specialized training from Ashram, which is in Chicago. I received extensive training on patient safety and human factors engineering. And I went back and was practicing as a patient safety officer in San Diego. That's when I met you, Patrick, in Orange County, California. What I love about patient safety is that you're proactively looking for where healthcare is going to fail. You're looking where humans might fail, where equipment might fail, or processes might fail, and you help to make it better. You help to make it safer, more resilient, and much less of a risk toward patients.
Yeah. I should point out the way we met, we were both asked by the AARC to attend the inaugural and subsequent summits of the Patient Safety Movement Foundation, sponsored by Massimo and Joe Chiani, who at that time was the CEO. And what got us, when we started chit-chatting about it, was the patients, family members, their friends, they would get up and share what a oops moment, a medical mistake made in terms of the impact on their life by losing a loved one. And I thought that just took a lot of gumption to get up there, but it changed the whole complexion of how we looked at patient safety by looking at the victims, not those that succumbed to it, but those that were their relatives, their loved ones. It was just impactful. And you have tears coming down your eyes when you hear some of these.
Yeah, when people make human error, and it's going to happen everywhere in healthcare, it doesn't matter how well educated or trained you are, humans make failures. We do make mistakes. One of the best things about working with patient safety officers is that even a person who makes a mistake, and it could be a catastrophic mistake, if you have that individual help to make it safer and prevent future harm, they can turn around their grief and that internal grief they have from being a person that harmed somebody. So patient safety is one of the most fantastic professions. I love doing it. I highly recommend any RT that likes to improve care that they look into the profession or the option.
Yeah. Now, it's the CPPS, the Certified Professional in Patient Safety, is the credential offered by the Institute for Healthcare Improvement. That's Donald Berwick's IHI out of Boston, which has been on the forefront of patient safety. And at the same time, we want to recognize that the AARC really continues on in the context of patient safety, because we have a patient safety roundtable where we actually share. And I can't tell you how important it is to have the concept of, once you have a mistake, investigate it and then do what you can to make sure it doesn't happen again. And every one of those people who get up and talk about their experience, that's exactly what they say they want. I want to make sure it doesn't happen to somebody again like it did to me. All right, now there's a new one out there. It's not new, it's been around for a while, the Certified Professional in Healthcare Risk Management, the CPHRM credential. And that's a new one on me. I'm going to have to ask you to tell me a little bit about that one.
So when I worked in California as the patient safety officer, I also worked in risk management, and they're intertwined. They work together. Risk management's a little bit more toward when something goes wrong and there's a harm event. Risk management is the group that works with the patients and the families to deal with the outcomes. So if there's a injury to the patient or there's a legal liability claim filed against the hospital, risk managers deal with that. So that's kind of, it's hit the fan. We have to deal with it. There's a lot of that area on investigation and working with attorneys and working with public health. It is very rewarding. It is a stressful area to work, but it's very rewarding because you can, again, help make change. The patient safety side is what I call the more proactive side. The risk management is more the reactive side that has to follow up after a negative event. But really, in most organizations, the two work together. So a risk manager will be proactively helping, just like a patient safety officer will help with the risk side. Yeah. So a lot of times you'll see either one of those credentials by people working in that area.
I think the great legacy from the National Patient Safety Movement was transparency. It used to be, I didn't want to squeal on my partner. I don't want to be someone who's speaking at it. But at the same time, the idea now is you see something, say something so we can make sure it doesn't happen again. And I think a lot of the reporting options in the hospital are basically trying to reduce the impact of those that come forward and identify a potential safety hazard.
Yeah, I try to tell people, don't have a culture where only really bad events are reported. You want every near miss or almost event, because those are a gift that tell you where your weaknesses are. So your patient safety officer can help, and clinicians and managers can help to improve that care so that risk will be reduced, harm events won't occur.
Right. It's really important to recognize it's not ratting out your colleagues. It's basically identifying areas where we can make an improvement so it doesn't happen again, because it's a human error, like you pointed out. It's not intentional. Most all the time it's not intentional. There are some scallywags out there, but for the most part, it's an accident oversight because of other purposes, and we can address it by a systems enhancement.
Yeah, majority of adverse events are caused by very complex patient care processes. And if we make them too complex, people start doing workarounds or they try to avoid some of the key details. So really working together to figure out how to make processes as good as can be, have redundancy, have fail safes if things go wrong, have barriers to prevent the human from making errors. It really takes people that are frontline staff to help figure out how to make care safer.
You're truly multitasking, and sometimes you go to do one thing and you get distracted because of an imminent emergency. And so multitasking is great, but in critical care and high-tech areas, it can be very, very dangerous. So the guardrails are very important, as you pointed out.
Yeah, you really have to look at the environment people are working in. So whenever an adverse event, because I always look in the context of the situation. What were they doing? What happened during that time?
Mm-hmm, mm-hmm. It's not punitive. It's basically trying to eliminate areas where we can do a better job, which is what performance improvement is all about. Now, the last time we talked, you talked about another new one that you're talking, new credential, the Certified Professional in Human Factors in Healthcare. That's a mouthful. And I'll give the letters of all these at the end of the podcast so our members can look on to the website and get further information. But what is this CPHFH and what have you found so far?
So this is a new credential that really focuses on human factors engineering in healthcare. And it's really important. Every time you work with your cell phone, you are working with one of the most advanced human factor engineering devices ever built. They constantly work with the end users to fix that phone to make it so intuitive and easy to use. But if we look back at how ventilators used to be compared to now, they were not always intuitive. They were made by amazing engineers, but the frontline staff weren't as involved in it. So human factors engineering is look how do humans interact with the technology and devices in the workforce. And we have to work better with our manufacturers to design devices that are more intuitive, have more safety barriers built in so that adverse events can occur. So human factors engineering is probably the most fantastic part of my patient safety career. It's the area that I've enjoyed learning as much as possible. So this is my credential that I'll be getting in the near future.
And I looked at the qualifications, and as long as you're a certified professional in patient safety and have your background in healthcare, you're going to be eligible to take that examination, which is really kind of a nice option. Again, 4 different divergent paths that are related, but yet somewhat peripheral to respiratory care.
Yeah, and I think that what it does is you can always reach out to somebody that works in that environment and ask that question. Mm-hmm. You can reach out to your quality department in your hospital. You can reach out to your patient safety officer and ask them, talk to them about the profession. And once you're on the radar, your chances of being able to get that position in the future opens up. And that's why getting that specialty credential, I tell people, it sets you apart from another applicant that just has the degree. Mm-hmm. If you have the degree and that specialty credential, that sets you apart from the other individuals.
Well, I'll tell you, Kevin, you've given our RT listeners many options, especially for those RRTs seeking ways to expand their respective career, both within the profession and also alongside the profession. And best of all, you speak from firsthand experience, which is why we invited you. I'm going to give you a chance for any final thoughts or words of wisdom for our listeners. It's your chance to kind of sum up and leave us on a high note.
So, Patrick, like I said to you before, I want every RT to know that your career is only limited if you keep yourself inside the box. I always tell people, lead from outside the box. You can go outside of just respiratory care and expand our profession so that people see us in a greater light. So speak up. Get on those committees, get in front of performance improvement projects, sit at the table. And I always say every hospital needs to make sure there's an RT at almost every nursing committee, every pharmacy committee. Mm-hmm. The more we're there, the more people see us, the more likely they'll accept us into these other positions. Yeah, no question about it. It's all team effort from now on. Well, Kevin, thanks so much for taking time from your busy schedule. And listeners, I told you I'd give you the letters so you can check these various options out on the internet. For the Certified Professional Healthcare Quality Credential, it's C as in Cameron, Paul, HQ, CPHQ. You just put that into Google and they'll take you right to that website. For Certified Professional in Patient Safety, it's CPPS. For the Certified Professional in Healthcare Risk Management, it's CPHRM. And for the Certified Professional in the newest, in Human Factors in Healthcare, it's CPHFH. Well, that brings us to the end of this episode of RT Matters. I want to thank you, Kevin, again, and to you, our listeners, for tuning in. Remember, we want to hear from you. Let us know what you like about this, what we can do better, and what really works for you as a respiratory therapist. Now, in the meantime, go out and be the best possible RT you can be. As Kevin pointed out, everybody's watching us, including the patients. So let's show that we really do indeed deserve that high accolade that we got because of COVID. Our patients deserve nothing less, and as a highly skilled, licensed healthcare professional, we don't expect any less from you. So until next time, be kind to yourself, to others, and remember, RTs do indeed matter.
Take care, be safe, and we look forward to having you back real soon.